Peter McCollough returns with Dr. Almendral, Assistant Professor of Medicine at Temple University, to discuss home-based management of heart failure with implantable devices.
This is Dr. Peter McCollough. Jojo, welcome to ACCEL.
Thank you for having me.
I want to start out with your ideas regarding the natural history of heart failure exacerbations in patients who have chronic heart failure and they're at home. Tell us a little bit about what's known. What are the precipitating factors, and how long does it take a patient to decompensate and really get to the point of going to the emergency room for hospitalization?
Some of the issues that we're having with heart failure, it's very prevalent in our society right now. There's about 5.8 million people with heart failure, and more than 670,000 cases are going to be diagnosed this year. And that translates into a $39.2 billion expenditure for our healthcare sector. About $20 billion of that is spent in hospitalizations, mainly due to hospital readmissions. So anything that we could do to reduce readmission rates will help bring down that expenditure.
So what happens in a patient that we're managing in the office, and what's happening in terms of their physiology to bring them to the point where there's a change in symptoms and ultimately pushes them to go back to the hospital?
Well, what we know now and from the recent clinical trials are that symptoms and signs of heart failure through physical examination are not sensitive enough to really make a big impact on readmissions. And that's because based on earlier trials with implantable hemodynamic monitors, they have come to find out that the onset of symptoms and signs of heart failure are preceded by elevated filling pressures 1 to 2 weeks before. So if we have a way of identifying that initial increase in filling pressures and intervene during that time before the onset of symptoms, we could prevent more heart failure readmissions.
So that's an important point, that what you're suggesting is that there's really a window of time that if we could know that the physiology is changing, we could intervene in some way. We could adjust medications, do some type of intervention to potentially improve the physiologic parameter and then ultimately avoid the hospitalization.
That's exactly right. And I think that's where cardiology is headed now. We are trying to intervene during that critical period where patients are not symptomatic but do have evidence of elevated filling pressures, and we could adjust their medications at that point and prevent readmissions.
So what type of monitors have been tried in clinical trials? Give us a general overview of cardiac hemodynamic monitoring for stable chronic heart failure patients.
Well, the best studied implantable hemodynamic device is the Chronicle device. And that is a device similar to a single lead pacemaker, where they have a generator implanted in the upper chest wall and a single lead into the RV. And through that lead, you could measure RV systolic and diastolic pressures and get an estimate of the PA diastolic as well as the PA mean pressures. You could also get a measure of patient's heart rate and activity. That implantable hemodynamic monitor was studied in the COMPASS HF trial. And even though the trial did not show a difference between management using the hemodynamic device versus routine clinical management, it did show that the device is safe and that it's reliable, and that most likely the trial was underpowered to show a big difference.
Now, what are the other kind of more modern types of implantable devices?
The recent study that came out was from the Champions trial, which used a different device. It used the CardioMEMS device, which is a standalone implantable device placed in the PA, in the pulmonary artery, using a catheter similar to a Swan-Ganz. And that device could measure your PA pressures. That was studied in the Champions trial, which has better enrollment and more patients compared to the previous Chronicle trial. And in that study, it did show that use of implantable hemodynamic devices and the hemodynamic data that they provide in adjusting heart failure management did have an effect on readmissions compared to usual medical care.
And what about the third device?
It's in clinical trials right now, but the results are not yet out. And it's a different device. It's implanted through a transeptal puncture, and it directly measures your left atrial pressure. So the advantage of this is that it measures your left atrial pressure directly compared to the other devices, which measure your pulmonary artery pressures, which are just surrogates of your left atrial pressure and your LV and diastolic pressure. So this device may be more specific and is more applicable, particularly in patients with pulmonary hypertension, where the PA pressures may not be reliable and may not indicate your LV and diastolic pressure.
So if you, in a perfect world, had this minute-to-minute, hour-to-hour measurement of left atrial pressure in a patient, and you started to see and were notified that the pressure was elevating, and elevating clearly above a baseline, clearly above normal, what type of intervention could be done that you're convinced could avoid a hospitalization?
A lot of the interventions done are increasing diuretics. Now, that is more or less correct in about 80% of patients, I would say. But one of the other interventions that you could do is increasing vasodilators. By doing one or the other, you stand a good chance of reducing heart failure readmissions.
Yeah, I know that principle is true, that in general, patients that have their medications adjusted in response to some type of physiologic variable, whether it be a sign, a symptom, a blood test, potentially a hemodynamic measure, it's the active titration of the drugs that does seem to result in fewer heart failure hospitalizations.
It is the active titration of the drug in response to some parameter, but I think that the parameters that we're monitoring right now, such as weight, symptoms, findings of elevated JVD on physical examination, are not very sensitive and very specific. And by the time you pick up those signs and symptoms, the patient could have had elevated filling pressures for a week or two, and by the time you make any interventions, it may be too late to ward off readmissions. So if we have a way of determining their filling pressures, even before the onset of signs and symptoms, then we'll be way ahead in the game.
But with these modern devices, won't we need forms of computer systems to track them and ways of getting output to doctors, and then doctors then responding to the information? Isn't that whole delivery part of the equation an issue?
There is a learning curve to it, and it certainly will involve handling more information than what we're used to, but there are a lot of ways around it. As the device industry progresses and implantable hemodynamic monitors become more commonplace, I think that there will be computer programs or algorithms that will initially monitor the hemodynamic data and just give out an alarm to the attending physician or to the nurse practitioner on measures that are out of range. And that will minimize the time that you spend going through all that hemodynamic information.
I see. So it really be episodic alerts.
It will be episodic alerts, and I think that in the years to come, that will get better. The way I see it is that implantable hemodynamic monitors may go akin to like what people are using now with diabetes, where the patients measure their own fingerstick glucose and adjust their insulin by themselves. I think in the future, patients will have access to their own hemodynamic data, and they could make day-to-day adjustments on their diuretics or on their vasodilator therapy under the direction of a physician, much like what they do with diabetes care now.
So heart failure in the future potentially could be a whole new world where we're guided not only with signs and symptoms and in some cases blood testing like natriuretic peptides, but also hemodynamic data. And I think the real challenge for us to learn how to interpret the hemodynamic data, not only with respect to episodic alerts, but also time averaging. And could it be possible that patients who time average left atrial pressure that's high and sustained high over time, that on routine visits that could be a call for adjustment of medications, that we could use these variables in a summated or averaged way over time?
It certainly could, and we are able to get some of that average information on some of their devices right now. We are able to get day-to-day information, we are able to get weekly information, and we are even able to get monthly information. So those patients who have been stable for, let's say, a month, and they're doing well, and the hemodynamic data has been steady, those are the patients that you probably could see in the office in 3 months. The ones where you get a lot of variability from day to day or week to week, those are the patients that may indicate that either they're having difficulty with compliance with medications or with their diet, and these are the people that you want to keep a closer eye on and maybe see them on a weekly basis or a bi-weekly basis.
Well, this has been a terrific summary of really an emerging field in cardiology, the area of implantable hemodynamic monitoring in heart failure. And just by talking to you, I get the idea that you're pretty convinced that this is going to become a reality in the future, at least for a subset of patients. Are there any final comments you'd like to leave for the ACCEL audience?
Well, I am convinced that implantable hemodynamic monitors will have a big impact in the future. We have to address these high readmission rates. And I think that this is the best thing so far that we have come up with that will make a big impact.
Excellent. I'll let that be the last word. And Jojo, thank you for joining us on ACCEL.
Thank you for having me.